Very good afternoon to all the delegates. I hope you all had a good lunch just now. And we are entering in our session 4 of the conference. And there will be 4 lectures for this session. And without further ado, I shall introduce our first speaker for the session, which is Clinical Professor Dr. P. Shanmuga. Just now, we already gave an excellent talk, and this will be his next talk on sentinel node imaging and the added value of SPECT-CT. That if for any questions, all can write it down first, and we shall have a question and answer session at the end of the session.
So good afternoon everyone. Once again my heartfelt happiness to be with you. So the topic we are going to discuss now is sentinel node imaging. So the technical and practical aspects of sentinel node imaging, and obviously what is the added value of SPECT-CT. So in the next 30 minutes or so, we will be discussing first what are the established most common indications to perform a sentinel node imaging, what is the radiopharmaceutical that is most preferred, what are the important acquisition parameters we should be keeping in our mind, how to do a probing with a gamma finder, some practical tips for individual sentinel node procedures, and of course we will be discussing the added value of SPECT-CT, not from the literature but with our own experience. I will be showing some images and will be highlighting the need for SPECT-CT. So what exactly is sentinel lymph node? To simplify it, it is the first draining lymph node which receives the lymphatic drainage directly from the tumor site. So it is a common sense to understand if there is harboring of malignancy in the lymph node, that means the entire lymphatic basin will have further tumor depositions. So if you can understand, identify the sentinel lymph node, and if it is taken up for a biopsy or FNAC or frozen section, and if it is negative, probably you don't need to disturb the lymphatic basin by doing a lymphatic dissection. If the sentinel lymph node is positive, then obviously you have to go ahead with the lymph node dissection. It is very important for us to understand whether it is whether it is breast, whether it is head and neck or gynae. If the sentinel lymph node is positive, it is positive majority of the time in early lymph node positive cases only by 15 to 20%. That means 80% of the time what we are doing as a lymph node dissection is only a waste procedure, producing more morbidity to the patient. So a sentinel lymph node becomes very attractive if you can identify, take out the node and prove that there is no malignancy. You can go ahead with the just a tumor removal and no lymph node dissection. That is the concept of sentinel lymph node imaging and biopsy. So these are some of the established and most practiced indications. Obviously all these indications are early cancers where the lymph nodes clinically or imaging wise is negative. The most common, the most widespread sentinel imaging has been performed for carcinoma breast, T1 to T4, but clinically negative, imaging wise negative nodes. In head and neck, we have the maximally the indication or the maximum experience is with oral cancers, tongue cancers, buccal mucosa cancers, and to a certain extent floor of mouth cancers. Again, the nodes should be clinically or ultrasound wise negative. The new indications and developing indications are early gynec malignancies, whether it is cervix, vulva or endometrium. Of course, this is an established procedure for skin malignancies. In Western countries, melanomas. In Asian countries, it is more of squamous and basal cell carcinomas. So, this statement is very important for practicing clinicians. When I can confidently say that I have a good experience and confidence with sentinel node, you have to perform at least 25 patients with less than 5% false negative rate and more than 96% success rate. What I mean, for the first 25 patients, irrespective of your sentinel node findings, they will go ahead and do the regular procedure, that is lymph node dissection on those patients, which will be proved we have not missed out the nodes in 5%, less than 5% false negative rate, and in more than 96% of the time I have shown the successful identification of the sentinel lymph node. So, once you fulfill this criteria, you can start doing sentinel imaging and biopsy by yourself. So, there are many radiopharmaceuticals available. Obviously, what we use is colloid, and the most established and most cost effective radiopharmaceutical is technetium labeled sulfur colloid, because it has a less than 200 nanometer size. It has a good labeling yield, 95% you can get it, and it should be always be a freshly prepared technetium sulfur colloid, and majority of the time we use a filtered sulfur colloid. Filtered sulfur colloid, obviously the heating is the crucial step. You should filter it with 0.22 microns millipore, that is the trade name in which the membrane filter is available. You have to keep it in your mind. If you want to have 800 microcurie of filtered sulfur colloid, you have to put 10 millicurie to 12 millicurie of unfiltered sulfur colloid, then only you will get it. So, there will be a significant reduction because you are filtering out all the large particles. You can also use, if you can access, antimony sulfide colloid or nanoalbumin colloid. So, what we prefer is nano colloids. If you cannot access or if it is too expensive for you, this is the most common, most cost effective filtered sulfur colloid. So, as a nuclear medicine physician, we should always update ourselves, and this is the new radiopharmaceutical of choice, that is tilmanocept. What is tilmanocept? It is a macromolecule targeting agent. It targets the dextran mannose receptors or macrophages on the dendritic cells in the lymph nodes, and the biggest advantage of that is it will not further move from the sentinel lymph node. Once it goes, it gets stuck to these dextran mannose receptors. So, you will not have more than one lymph nodes, and this is available in the trade name of Lymphoseek. Right now, it is available only in Western countries, too expensive, but it is the most ideal radiopharmaceutical right now. So, these are some of the practical tips which we must know if we are starting a sentinel lymph node program. Whether you are going to do a 2-day protocol or a 1-day protocol. We prefer 1-day protocol for oral malignancies. You can do 2-day protocol for breast and gynae malignancies. For gynae malignancies, most of the time we do a 2-day protocol, and we use as less radiation producing radiopharmaceutical as possible. Majority of the time we use only microcuries, and we don't really need to give any local anesthetics. It has been proved that local anesthetics can impair the movement of the lymphatic particles, so we don't use any local anesthesias in the injection of the radiopharmaceuticals for the sentinel node image. The selection of radiopharmaceutical, as I told, filtered sulfur colloid or nanocolloids. We need to optimize the acquisition parameters. We should know when to do the imaging, what type of imaging we are going to do, whether we are going to do a planar imaging or are we going to do a dynamic imaging, or when a SPECT-CT is to be used. And if I don't have a SPECT-CT, does it mean I can't do a sentinel? Not really, still you can do the sentinel. So these are some of the things we will be discussing now. We will go individually, we will go by individual areas. The first one is the head and neck sentinel imaging. We must keep it in our mind, in head and neck there are 400 lymph nodes, more than 400 lymph nodes. So these nodes are very small, and you can see the migration of the radiopharmaceutical is too fast. So you have to do, if possible, a dynamic study, or immediate static images you have to do. And there are lots of issues in head and neck, especially oral cancers, because the primary is too close to the secondary lymph nodes. So you need to know when to inject and when to start the image. So it is always a peritumoral injection. You can see the injection is just along the border of the lymph node, border of the primary. We have to give a minimum of 2 injections, maximum 4 injections. Each injection is 0.1 ml, and it should have a minimum of 100 microcurie to 200 microcurie. Immediately after the injection, you should either do a planar image, or if possible you can do a dynamic study, but by the time you inject, you position the patient, the lymph nodes will be seen clearly. So this is an excellent image. You can see this was acquired within 5 minutes after the injection. So this is the injection area on the tongue, and this is the lymph node on the right side, possibly the left level 2, right level 2 node, and this can be marked on the skin. If you don't have a SPECT-CT procedure, then you can mark on the skin so that surgeon knows which area it is. It is also important, you can see this is an image which was acquired within 5 minutes. You have already seen 3 lymph nodes on the left side, left level 2 nodes, and possibly left level 3 the 3rd node. So the transit of radiopharmaceutical filtered sulfur colloid and nanocolloid is instantaneous in the tongue cancers and buccal mucosa cancers. So you have to be well prepared. You should have excellent confidence on the injection, and immediately you should start the image. Not only that, you can actually have contralateral lymph nodes. What do I mean? So this is an image which shows the primary injection site. There is a sentinel lymph node on the right side, but actually there is another lymph node on the left side also. This would have been missed if you had not taken an anterior planar image. So what I want to highlight here is, you will be doing 2 imaging. One is a right lateral or a left lateral planar image, followed by a anterior image, so that you know, is there any contralateral lymph nodes. 20% of the time there can be contralateral lymph nodes. Not only that, it is really a challenge to do a sentinel imaging in head and neck, because patient cooperation is maximum, should be there, because there are 2 problems. One is, it is really difficult to inject these friable small tumors, number 1. Number 2 is saliva contamination. The patient, if the patient swallows saliva, then your entire study can be missed out, because you can see there is a lot of tracer in the oral cavity, and also there is a lot of tracer in the esophagus. This all can mask the small sentinel lymph nodes. So patient is to be made understand how to do and how to cooperate with our studies. Timing of imaging to surgery. We should not do the imaging too early, because there will be further transit of tracer and there will be too many lymph nodes. The surgeon can get more confused. That is where the patient SPECT-CT helps. Let me explain it why a SPECT-CT is important. Here is a planar image, shows the primary, there is a lymph node. We have done a SPECT. In SPECT, we have found out two spots, but we don't know really the anatomical localization. That's where a simple SPECT-CT helps. You can again see there are two lymph nodes. One is a level 3 right small lymph node. It is around 4 to 5 millimeter, and there is much smaller node on the opposite side, that is left level 3 node. So exact anatomical localization is possible only with SPECT-CT. So a simple SPECT may not be helpful. It is as good as a planar image. So what are the other advantages of a SPECT-CT in head and neck? You can see it delineates even 2 millimeter lymph node. No skin markings are needed. The surgeon is extremely confident because we are able to identify whether it is a level 2 node, whether it is a level 3 node, and there is no interference of the primary injection site because of this exquisite anatomical detail with an excellent co-registration of the SPECT image. So we can actually have accurate localization, and also we can be 100% sure that there is presence or absence of contralateral lymph nodes. So this is a good tool in the decision making of radical neck dissection, which level is to be radically removed, whether it is a unilateral radical neck dissection or whether it is a bilateral radical neck dissection, depending on the results from the sentinel lymph node that we are picking up by our imaging and by probing. Coming to the breast, there are two important tips everybody should be knowing. One is, although there are multiple injection techniques, the only injection technique which will give excellent constant result is the periareolar injection. So what do we mean by periareolar? You will be injecting at the areola cutaneous junction, because if you inject on the areola, it will be too painful for the patient. So you can inject at the areola cutaneous junction, meaning you will enter from the skin and you will end up at the areola. You will be giving 2 to 4 injections, 0.1 ml every time. And what is the biggest advantage of this periareolar? Wherever is the tumor, whatever be the depth of the tumor, you will always get the correct lymph node in the axilla. You will not miss out any lymph node. Your success rate will be 100% with this periareolar injection technique. So that is what I wanted to show here. The periareolar means you will always end up with only one lymph node majority of the time. And if it is a peritumoral injection, you can have multiple imaging or multiple lymph nodes being imaged, number one. Number two is, sometimes the scan can be negative also. That is, this imaging can be negative. So always try to do periareolar injection. What is the role of SPECT-CT? It is really relevant in identifying whether it is a level 1 or level 2 or level 4 axillary lymph nodes. So it gives a good idea to the surgeon where to approach. So majority of the time when he sees an image like this, he will be very happy. Okay, this is the area where I have to target level 1 or the other levels. Coming to the most difficult area of sentinel, gynae sentinel imaging. It is really a challenge. So there are some practical tips which I am explaining it here. One is with reference to cervix and vulva. So these are more superficial tumors. If there are tumors which are palpable, then you will go for a peritumoral injections, meaning if it is T2, T3, the tumors are palpable, you can inject above the tumor, of course with the help of the gynecologist in the labor theatre. Or if it is a carcinoma in situ patients, then you will inject in the cervical orifice, the 3, 6, 9 and 12. There are 4 positions. Even if you give 2 injections, you will get the node positive, or node detection will be possible. So majority of the time you are either looking for a intrapelvic, internal iliac or external iliac nodes. Majority of the time you will be able to see it within 20 minutes to 30 minutes, or sometimes if it is a deeper one, you will have to wait till 2 to 3 hours. That's the reason I told it is ideal to do an imaging the previous day, so that surgeon in the morning doesn't get tensed up. And you can also look for the contralateral nodes. So this is a patient, carcinoma cervix, palpable tumor, peritumoral injection given, and the sentinel lymph node you are able to see on the left side. This is a obturator lymph node. On the other hand, this is a patient who has shown 2 nodes both on the left side and on the right side, and this is a vulval patient. This is a node in the right internal iliac. So these are the normal imaging which you can do, but obviously just by a planar image you will not get convinced whether this is a internal iliac, external iliac or an obturator image, and that is where the SPECT-CT will be helpful. Now coming to the endometrial injection technique, it is very important to understand there are 2 ways of injecting the endometrial cancers. One is the previous day cervix injection. So here you will be doing a cervical lip 3, 6, 9 or 12 o'clock position. Again, even 2 injection is good. That is one way of injecting the patient. The second way is peroperatively. The gynecologist operates, opens up the abdomen, shows the myometrium or shows the uterus, and intraoperative intramyometrial injection. So that is what you can do. That is the second way of injecting. And the third way is you can combine both. It has been shown the sensitivity improves, the sentinel lymph node detection sensitivity improves if you are doing both injections. But in practice, this may be the best one. Do an endocervical injection the previous day, and the next day you probe the patient. So another important thing, especially in centers like ours, we have robotic surgery also. So in robotic surgeries, you don't have an option of peroperative injection, and we don't do endometrial sentinel lymph node detection. You can use ICG. The indocyanine green is the preferred dye that is used, and this is a dye method. So there is equal sensitivity between ICG injection and sentinel scintigraphy as far as myometrial and endometrial injections are concerned for the endometrial cancers. So now in the next 5 minutes we shall be seeing some of the images of the sentinel lymph node detection in cervix, vulva and the endometrium. What is the real role of SPECT-CT? So as we were discussing, the iliac nodes are the most common site of sentinel lymph node. So whether it is external or internal. So when you see an image like this, you know that it is intrapelvic, but here you are very confident to say that this is external iliac or internal iliac. How does it help? The surgeon can remove only that group of lymph nodes, and he can do a better lymph node sampling, and he can go ahead with the pelvic lymph node dissection if the frozen is positive. This is also helpful when you see more than one lymph nodes. Here is a patient where we have picked up left internal external iliac lymph nodes. It has gone up to para-aortic lymph node. So which is the first lymph node? Obviously, because of the intensity of the tracer uptake, this is the first lymph node, and that can be compared in a SPECT-CT. This is a left internal iliac lymph node. In cervix, there are 2 important decisions we have to take. One is whether it is a iliac lymph node or is it an inguinal lymph node. So sometimes it is really difficult. For example, in this particular patient, the injection is done here and there is a lymph node. Is it a high up inguinal node, or is it a internal iliac lymph node? When you do a SPECT-CT, you are very clear that this is only a inguinal node. Obviously, the surgical approach changes. Cervix and vulva, you can actually have the inguinal node as the sentinel lymph node. So that is what is shown here. Carcinoma vulva, almost always it is the inguinal nodes, which is the sentinel lymph node. Again, easy to understand from the simple SPECT-CT. Whatever be the strength of the X-ray you are using, still it will be really relevant to you. So the same thing applies to the male reproductive organs like carcinoma penis. Here also you can actually show whether the inguinal, majority of the time it will be inguinal nodes, but it can also go into the intrapelvic lymph nodes. Skin, this is again an area where sentinel lymph node has played lot of role, and I have more than 100 images to show where so many scans we have done. I will just show one or two so that I don't bore you. At the same time, to drive home the point, what is the role of SPECT-CT? So this is a sole injection. This is an already amputated area. So injection is very difficult. You must understand the fact that sole is an area difficult to inject, but you have to give good injection. And what is the tip here? You have to inject just 1 centimeter away from the margin, and volume is very difficult. You have to inject, you cannot inject large volume, so it should be in small volume. And this is the most important tip for both technologists and for the clinicians. When you do imaging for the lower limb, you have to take an 18 centimeter per minute speed, scan speed, whole body. That is what I mean is the lower limb and the pelvis should be covered. So what is the relevance of that? If you are injecting the tracer in the plantar aspect or the plantar aspect of the foot, you can either have the inguinal node as the sentinel, or you can actually have the popliteal node as the sentinel. So which comes first? You cannot make out if you do a static image. So that's where you have to immediately after the injection, like a dynamic study, you have to do a whole body imaging or a whole lower limb imaging. Obviously, you are injecting in only the affected side, so only one side you are seeing, and the scan speed should be faster, 18 to 20 minutes, 20 centimeter per minute. But it can go wrong in many places. So this is a patient who is having a thigh malignancy, malignant melanoma. In thigh, what we should be expecting is it should be in the inguinal node, but it need not be always inguinal node. It can go to the pelvic node. Sometimes it can even go to thorax. So we have to know, this is where the SPECT-CT is really helpful. So it may look very ugly to all of us, but it is a highly relevant image as far as the injection technique is concerned. This is a patient who had a surgery for his fused fingers 40 years before, and now presenting with a non-healing ulcer, very difficult to inject. But what is the advantage? You are able to show a axillary lymph node. So patient has kept the hand like this. The imaging is done from up to down, and this is the injection site, and you can see a small lymph node, that is the axillary lymph node. Again, what is the relevance? This can be node in the elbow, that is the condylar lymph nodes, or epitrochlear lymph nodes, or is it axillary lymph nodes? The imaging technique is very important. You can have squamous cell carcinomas anywhere. So this is in the upper abdomen, lower chest. It can either go into the chest lymph nodes, it can go into the intra-abdominal lymph nodes, or it can even go to the axillary lymph nodes. So what is the relevance of SPECT? This is the planar image you are seeing. Nobody can make out anything in this. But when you do a SPECT, you are able to show very clearly a focus of uptake in the right axilla. So this is the relevance of SPECT-CT. So use the SPECT-CT correctly at the correct indications is exemplified in this patient. So what we have understood in the last 30 minutes, we need to have our own protocol. We need to standardize our own protocol starting from the indication, the radiopharmaceutical preparation, the injection technique and the image acquisition. So it is important that one of the clinician takes interest, one of the technologists takes interest in standardizing these areas and repeatedly doing by himself or herself. Then only we can taste success. Obviously, we need to have a very close interaction with the oncology team. We should highlight to them which are the right indications, and we need to establish the imaging indications. For example, in India, we have more of carcinoma, breast and head and neck cancers. On the other hand, in Western countries, I have seen more of skin malignancies and breast malignancies. So, which are the common indications we have to discuss with our oncology, and we need to develop all these things. Of course, we have understood by this time that SPECT-CT is an integral part of Sentinel lymph node. At the same time, I like to highlight, when we started our head and neck program in 2003, it is going to be 20 years. At that time, I did not have a SPECT or I did not have a SPECT-CT. Still, we were doing Sentinel node program by skin marking. So, obviously, we need to have a start, and anybody can start this at any time. Thank you very much for your patient hearing. So, at this point, I like to highlight to you, we are going to have a live Sentinel node imaging and biopsy national workshop. This was conducted in 2016 in our institute. We are going to repeat it in 2023. So I am welcoming all of you to join for this. This is going to be a very good program. 2 days it will be, and you can learn, you can see live how a Sentinel node imaging is done and a Sentinel node lymph node biopsy is done intraoperatively. So we had around 200 delegates last time, and this time I like to see all of you there so that you all will be benefited. Once again, welcome to Cochin, the capital of or the most important city of Kerala, and this is called as God's own country. It is going to be one of a very good tourist destination for you also. Welcome once again. Thank you very much.
Thank you very much, Prof. Dr. Chandra, for the excellent talk. We shall move on to our next talk, and we shall take any questions at the end of the session. For those virtual delegates, you can write down your questions in the chat box. The next session is a pre-recorded one by Dr. Khor Phay. Just a brief introduction. Dr. Khor Phay graduated from the National University of Malaysia in 2004 and obtained her Master of Nuclear Medicine in 2013. She had fellowship training in Pediatric Nuclear Medicine at the Children's Hospital at Westmead, New South Wales, Australia in 2018, and is a fellow of Asian Nuclear Medicine Board. So, please. Thank you.
Warm greetings from Kuala Lumpur and a very good afternoon to everyone. Thank you, Chairperson, for the kind introduction. Firstly, I would like to thank the organizer, Dr. Ng and Dr. Jason, for inviting me to speak in this conference. It is indeed my pleasure to be part of this event. As much as I would have loved to be there physically, however, due to work commitment, unfortunately, I could not attend in person. Thanks to virtual platform now that I can present to you virtually. The title of my presentation is The Role and Challenges of SPECT-CT in Pediatric Population. Pediatric nuclear medicine is unique in its own way as it requires a tailored and innovative approach dedicated for children in the aspects of study acquisition and in providing a children-friendly environment. This is the outline of my presentation. I'll be illustrating cases to highlight the role of SPECT-CT in oncology, in lymphatic abnormalities, musculoskeletal, and other interesting cases. Over the years, there has been an increasing demand for SPECT-CT in pediatrics imaging. Hybrid SPECT-CT imaging is becoming the standard of care of pediatric imaging. The indications are mainly focused in oncology cases like MRBG in neuroblastoma patients and iodine 131 scintigraphy in differentiated thyroid carcinoma patients. There is an increasing role in lymphoscintigraphy, musculoskeletal, and hepatobiliary imaging as well. SPECT-CT provides improved diagnostic accuracy. It can reduce the number of equivocal studies and the need for further diagnostic tests. Of course, it requires a tailored approach to determine the correct indication at the time of study request. And we need to optimize the protocol and study performance at the time of the scan acquisition for both the SPECT and CT components. This may include multiple SPECT acquisitions, optimized CT with dose modulation, and appropriate KBB selection. SPECT-CT in oncology mainly focuses in MRBG scintigraphy for neuroblastoma and iodine 131 scintigraphy or iodine 123 scintigraphy for differentiated thyroid cancer. The added value of the co-registered optimized SPECT-CT can provide increased specificity of the study, increased sensitivity for lesion detection, improved localization of lesions, help to identify benign physiologic activity, and detect incidental, potentially significant findings. This is a 3-year-old boy with 2-month history of leg pain, anorexia, and fever. So from these MRBG scans, you can see there's a large MRBG epidisease in the abdomen with multiple skeletal metastases. And on follow-up, the mass becomes smaller and did not show MRBG uptake. The second case is a 5-year-old boy, neuroblastoma on surveillance. Residual mass noted at the left paravertebral region on CT. So from this planar imaging, there is a small uptake seen at the left paravertebral region. So SPECT-CT shows, on SPECT-CT, it shows that the left paravertebral mass does not show MRBG uptake. A 5-year-old girl with stage 4 neuroblastoma, post-treatment had a recurrence at the right lateral orbit. So SPECT-CT provides information for exact localization for radiotherapy. In this paper, SPECT-CT in Pediatric Patient Management by Helen Madden, it highlights a case, a child on treatment for neuroblastoma for restaging when presented with recurrent neck mass. Whole body imaging shows focal activity in the upper abdomen, which could represent either physiological adrenal or bowel activity or possibly bone or soft tissue disease. SPECT-CT clearly identifies the abdominal activity to be a focal metastasis to the right psoas muscle. And this paper, MRBG in neuroblastoma diagnostic imaging and therapy by Susan Sharp et al., showing a neuroblastoma in a 10-month-old girl. So the planar imaging looks fairly normal. SPECT-CT shows there's a left paraspinal primary tumor, and this tumor is obscured by the physiological cardiac activity. on planar imaging. But of course, when we do a SPECT-CT, we can see that homogeneous MLBG uptake in the left paraspinal primary tumor. Another case, a 2-year-old boy presented with a large abdominal mass with central necrosis arising in the superior pole of the right kidney. There is displacement of the right kidney inferiorly. So MLBG studies did not really show any obvious abnormalities. SPECT-CT shows that the large abdominal mass does not take up MLBG. So could this be due to necrosis or primitive dedifferentiated tumor? So we proceeded with fluorine-18 FDG PET-CT, and it clearly shows that the large abdominal mass is taking up FDG. Compared with SPECT alone, SPECT-CT can further improve certainty of lesion detection and uptake localization. SPECT-CT is especially useful for characterization of small retroperitoneal foci because sites of pathological activity, that is nodal disease or residual tumor, and physiologic activity, that is the adrenal glands and urinary activity, are both common in the retroperitoneum. So another case before we move to the next branch. So a 10-year-old male with hypertensive crisis. So we can see uptake at the bilateral adrenal. This is a bilateral pheochromocytoma. The patient came back with follow-up study, and there's an uptake seen at the mid-abdomen as well as an uptake in the bones. So the uptake in the abdomen clearly localized to a lesion at the right adrenal. Now we move to the second most common oncology cases that utilize SPECT-CT. 10-year-old girl with history of total thyroidectomy and left modified radical neck dissection. HPE came back as multifocal PTC in both lobes with lymphovascular invasion and cervical lymph node metastasis. So patient had first ablation and there's a large neck uptake, stimulated TG of 100 or 105, and second ablation, the neck uptake has become smaller, but stimulated TG is in increasing trend, now becoming 167. Because of that, FDG PET-CT is arranged to look for dedifferentiated thyroid cancer. And from the PET-CT, it shows that there's a lesion at the left sacral ala, and also there's a lesion at the presacral. It's a soft tissue lesion. As the locations of the FDG-avid lesions are rare, MRI was arranged, and however, it is inconclusive. And eventually, patient had the third RAI, and here you can see that there's a faint uptake in the neck. SPECT-CT shows that the uptake corresponds to a soft tissue lesion at the right thyroid bed. Stimulated TG at this time is coming down to 16.9. So in conclusion, there's a residual iodine-avid disease in the right lower thyroid bed and FDG-avid left sacroiliac metastasis. In view of the stimulated TG showing a significant reductions without detectable anti-TG antibody, there is overall improvement in the disease burden. Another case is a 12-year-old male with multiple nodules at bilateral thyroid lobe, dominant left nodule with cervical lymph nodes. Total thyroidectomy and extensive lymph node central and lateral compartment was performed, and mediastinal dissection as well. So 100 millicurie was given in view of the local regional disease. Post-therapy scan showed extensive nodal disease at bilateral cervical and upper mediastinum. In follow-up, 6 months later, neck ultrasound is negative and TG is 6.4, and the whole body scan shows there's a small lesion uptake at the left upper neck, and with CT it adds better anatomical localizations to level 2B cervical nodes. So what do you do? What do you do next? Should we continue to give radioactive iodine, or we go for surgery? So in this case, surgery was performed with gamma probe, in which they removed the 2 nodes which has this confirmed metastatic involvement. Post-treatment whole body scan is recommended for all children 4 to 7 days after RAI therapy. Addition of SPECT-CT may help to distinguish the anatomic location of the focal uptake. SPECT-CT improves specificity of imaging in children post-surgery for thyroid carcinoma, as it provides better localizations of neck activity with hybrid study than planar imaging alone. So from SPECT-CT in oncology, now we move to SPECT-CT in lymphatic abnormalities. Lymphoscintigraphy is a safe and minimally invasive procedure that provides essential information on the functional status of the lymphatic system. It's crucial in the investigation of chylothorax and lymphatic dysplasia. SPECT-CT can accurately localize the tracer accumulation in the lymphatic or chylous lake in the lung or abdomen. Add further functional information relating to dermal collateralization of lymph flow, dermal backflow, or other lymphatic malformation. In chylous lake in the abdomen, it is useful in determining the site of lake and confirm low level of activity in the gastrointestinal tract. This is a 3-week-old infant with Noonan syndrome, intubated and ventilated. And to look for chylous pleural effusion. So injections of technetium antimony sulfur colloid was given intradermally. So we can see rapid lymphatic transit was traced in 1 dominant lymphatic collectors in each lower limb, reaching bilateral groin by 5 to 10 minutes. And at 30 minutes, still stays at the groin nodes. And at 3 hours, there was persisting uptake in bilateral groin limb nodes. There was uptake in 1 right iliac nodes. However, there are now multiple abnormal findings where there is non-visualization of more proximal iliolumbar lymphatics and lymph node, no increase in the hepatic uptake, and diffuse activity in the soft tissue of both lower limbs and the lower abdominal wall, consistent with lymphatic transit through the subdermal lymphatic plexus, which we call as dermal backflow. And it's confirmed on SPECT-CT. So what do we do next? There's no migration of tracer beyond the groin nodes. So we inject in the second dorsal web space of both hands. So if you remember that this is a 3-week-old child, it's very small, and when we inject at hands, this causes significant star artifact. We cannot even visualize the migration of the tracer. So what do? We place the baby's hand into flat pot to shield the uptake. And this is actually so that we can visualize the lymphatic drainage up to the axillary region. And we can see that now there's this diffuse uptake at the right hemithorax activity, localized to the small right pleural effusion consistent with Khor lake. Go to the next case, which is a 5-month-old baby with chronic cough and shortness of breath for 2 months. Right pleural effusion confirmed Khor, so initially managed conservatively with TPN, fat-free formula milk and octreotide infusion. But as the liver enzyme derange, eventually TPN has to be stopped. So this child was referred for functional assessment of the lymphatic system prior to surgical intervention. So we inject TC nanocolloid intradermally into the second and third blood space of the toes on each limb. So dynamic imaging shows that normal uptake, normal drainage up till the lower limbs. And as the study progresses, a focus of uptake is seen at the mid-upper chest, which corresponds to the level of T3 on SPECT-CT. And this shows that there is right color thorax with probability of leakage site at T3. Intraoperatively, the surgeon found that there's a right thoracic lymphangiectasia, a small lymphangiectasia lesion at the right lower lobe. Excision of the lymphangiectasia with decortication of the parietal pleura, pleural disease and thoracic duct ligation was done, and it confirmed lymphangiectasia. So post-op, patient was ventilated for a few days and chest tube was successfully removed, and the color thorax was completely resolved. So congenital pulmonary lymphangiectasia is a rare developmental disorder characterized by lymphatic dilatation of subpleural, interlobar, perivascular, and peribronchial, present as a result of congenital defect in the primary development of the lung, or may present as a localized expression of generalized lymphatic involvement, that is truncal lymphangiectasia, which is commonly associated with lymphedema. Lymphoscintigraphy with SPECT-CT is useful for evaluating lung lymph vessel involvement by showing tracer accumulation in the lung and by providing evidence of backflow within the thoracic duct. It has an important role in pre-surgical planning, especially in cases of intractable color thorax. So this paper, Lymphoscintigraphy in Pediatric and Adolescent Patients by Howard Giles et al., which is my supervisor, highlight a case of a 9-year-old male with hypoalbuminemia, low lymphocytes and immunoglobulin, elevated stool alpha-1 antitrypsin level. So initial scan shows that normal lymphatic collectors extending up to the femoral, inguinal, and iliac nodes, while diffuse uptake is actually seen at the left upper quadrant. Delay imaging shows that the diffuse pattern of tracer at the mid and left upper abdominal quadrant with no activity in the liver. SPECT-CT shows diffuse accumulation of tracer in the mid and left upper quadrant of the abdomen, corresponding to small bowel activity, mainly within the jejunum. In video capsule endoscopy showed scattered area of lymphangiectasia within the jejunum. So now we move on to the third branch, which is SPECT-CT in musculoskeletal. Bone scintigraphy with SPECT-CT has been utilized for evaluation of back pain in children. In occult trauma, SPECT-CT has proven particularly useful in neurodevelopmentally delayed children who are often non-verbal children who cannot localize their symptoms and often only present to their caregivers with change in behavior. The SPECT-CT can identify both the bone and the soft tissue lesion. In congenital abnormalities, congenital fusion variation in skeleton can be characterized beyond an area of increased activity. In spine, these fusion abnormalities can occur in the lower lumbar spine as transitional vertebra and can be a cause of back pain. 3-year-old boy limping, favoring right leg. Patient has fever. So could this be infection? Then X-ray is normal. So from the blood pool, there is an diffuse, there's uptake seen at the left proximal femur. And on delayed images, you can see that it clearly shows at the femoral, left femoral, proximal femoral. And on SPECT-CT, the uptake is at the left proximal femur. Is there any collection? No. So patient is put on antibiotics for 6 weeks. So if there is collection, surgeon will have to go in for surgical intervention. A 3-year-old male refusing to walk with some restriction of back movement on examination. So this is a case of discitis. 13-year-old girl with motor vehicle accident fractured the neck of the left femur. So sent for bone scan to see is there any avascular left femoral head. Pinhole shows that there is increased uptake at the left femoral head. So it is with SPECT-CT, there is clearly visualized that the femoral head is vascularized. So it's not avascular. Another case is a 14-year-old girl with anorexia nervosa. So treated, and when bone marrow density has been normal, the child go back to schools, increase activity, but as he runs, she has pain in the left heel. X-ray was normal. Shows that there's a fracture at the body of calcaneus. So bone scintigraphy with SPECT-CT has also been utilized for evaluation and potential preoperative planning of mandibular growth asymmetry in children. SPECT-CT is used to evaluate the growth cessation of the mandibular condylar hyperplasia, hence influencing the timing of surgery. Benefits of additional CT, precise ROI to be drawn using CT anatomical contours. So this will reduce inter-observer variations in the ROI placement and improve SPECT image quality by using the CT component for SPECT acquisition for SPECT attenuation correction. So we move to the next branch of my topic, which is SPECT-CT in hepatobiliary imaging. This is useful in biliary leak post-surgery or post-liver transplant. Bowel leak can either be free-flowing within the peritoneum or localized, with or without communication with the drains. In free-flowing intraperitoneal leak, there is accumulation of tracer in the subhepatic region, followed by right paracolic gutter, suprahepatic region, and along the periphery of the liver. However, it can be found in any peritoneal space. So it's important to acquire SPECT-CT images if a leak is suspected in the subhepatic region or in the greater or lesser sac in order to differentiate from radiotracer presence in bowel loops or stomach. Familiarization with normal variants seen on CD, as seen on HIDA, and correlation with SPECT-CT image or other anatomical images are necessary to avoid false positive results. Knowledge of the type of drainage tube used and verifying the tube position on anatomical images. HIDA may depict peripheral leaks not seen in ERCP due to the retrograde filling of the bowel ducts. So this is a 15-month-old girl, day 4, post-open choledochosis excision and hepatico-duodenostomy. Fever, fluid distension, ultrasound shows fluid collection in portal hepatis and peritoneal free fluid. So here you can see that the bowel excreting into the GIT tract, but also tracking into the right subdiaphragmatic. So SPECT-CT clearly sees that localize the link to the right subdiaphragmatic and portal hepatis at the site of surgical anastomosis. So we go on to the few rare cases. 11-year-old boy with persisting colorectal bleeding. So if you can see from this echo scan, there's a small focus of uptake at the right iliac region. And it actually comes at the same time simultaneously with the stomach uptake, increasing over times. But the location of this uptake looks so much, raise the possibility of the bladder diverticulum. So SPECT-CT was performed, and it identifies the focus of activity to a partially gastric loop of bowel at this location. So this is an ectopic functioning gastric glucosa within the right iliac fossa, consistent with Meckel's diverticulum. Another case is of SPECT-CT in these interesting cases is an 8-year-old girl for patency study of his right-sided BP shunt. And his left-sided BP shunt was tested a few days ago. So on the initial images, the radiotracer did not reflux through the right ventricular catheter into the intracranial CSF spaces. However, the radiotracer descended the right peritoneal external catheter freely with intraperitoneal dispersion within 5 minutes post-injection. So left ventricular peritoneal shunt injection was done through the left frontal recurrence reservoir to assess the left BP shunt. And from here, there's an large overt focus of uptake seen in the left upper abdomen, and SPECT-CT shows that this large fluid density collection anterior superior to the pancreatic body tail, abutting the splenic hilum and inferior to the gastric body. And this is a pseudocyst. Children are inherently more sensitive to environmental hazards, including radiation. They have more proportion of proliferating cells, and they have a longer lifespan to develop long-term health effects. So SPECT-CT comes with additional radiation dose to patients. Should we do SPECT-CT or not? If yes, which cases? Patient has a recent CT scan. Should we do SPECT only and co-register with CT? And at times we have to deal with parents for their concern of cancer risk. So there have been papers published highlighting the risk of cancer in patients exposed to CT scan in early childhood. So every examination must be tailored on an individual basis and should only be performed after appropriate justification and with adherence to optimized low-dose pediatric protocols. We should hold this closely to our heart. In everything we do, we should make sure the benefits outweigh the risks. So there are a few efforts that has been ongoing. First is image gently. Second is go with guidelines, web-based tool, pediatric injected activity tool, and equipment and radiation dose tool by SNMMI and image gently. And there's also EANM dose card to guide us. So this image gently is a collation of healthcare organizations dedicated to providing a safe, high-quality pediatric imaging worldwide. The primary objective is to raise awareness in the imaging community of the need to adjust radiation dose when imaging children. So they have alliance organizations all over the world, including Malaysia. Go with the guideline. We have to make sure everything we do, the procedure is justified and we have to optimize it. So we do the procedure right. Just showing the dose card, the web-based pediatric injected activity tool. So even though we are focusing that additional CT will increase the radiation exposure to the patient, we should remember that with the injection of tracer, there is a radiation dose as well. So important to refer to guidelines, utilizations, patient education, optimization of current protocol, and software. Nowadays, there are advanced image processing software which can give us a better image quality, requiring much lower counts, and we can lower down the patient dose. So of course, we should not forget dose optimization in CT. So there are protocols specific to age, body size and composition, tube voltage. So we should lower the kVp, MAS unchanged. So reduce the radiation dose and improve image contrast for small size patient. This can be applied for high subject contrast tissues like chest and bones. However, in contrast enhanced soft tissue procedure, that is to assess small lesion in the abdomen, sometimes we just have to use a higher kVp. Newer system has automatic tube potential selection with tube current modulation, so that takes away our headache. Tube current. Now, a lot of tube current modulation. The system itself will automatically adjust the MA based on the size and attenuation properties of the body, in which it can reduce the dose to 50%. And there are many iterative reconstructions to guide this. We can optimize scout view, optimize pitch and scan collimation, overscanning, and overbeaming. So CT protocol is depending on the application. If the CT is truly for attenuation correction, both kVp and MAS can be reduced to almost as far as the device will allow. In many cases, low-dose CT is used for anatomical correlation of the SPECT data. So in this case, the CT image quality may only need to be sufficient for localization and less than that necessary for diagnosis. It's important to optimize existing protocols and improve communication with patients and caregivers. So as a conclusion, we should work our best according to the guidelines and local practice, do the right tests for the right indication at the right time. Whatever we do, make sure the benefits outweigh the risks. I'd like to take this opportunity to acknowledge my professor, Dr. Robert Holland Giles from Westmead Sydney Hospital, and Professor Dr. Yong Chai Hong for sharing some of the slides. Thank you for your attention.
Thank you, Dr. Phay, for the talk. She will be available online with us during the Q&A session if time permits. We shall move on to the next talk by Clinical Professor Dr. Padma. Clinical Professor Dr. Padma is a consultant nuclear medicine physician at the Amrita Institute of Medical Science in Kuching, Kerala. She became a diplomat of the National Board of Examinations in Delhi in nuclear medicine in 2015 and became a fellow of the Asian Nuclear Medicine Board at ANMP in the same year. Dr. Padma is a recognized teacher and examiner for postgraduate training in nuclear medicine course and has published 130 national and international publications, 4 chapters in postgrad Indian textbooks of radiology, gastroenterology, and general surgery. She regularly provides lectures in multiple national and international conferences.
Okay.
Please welcome.
That is for the next. Thank you so much. I take this opportunity to thank the Malaysian Society of Nuclear Medicine, Chairman and the organizing secretary for this opportunity. It's my pleasure to be part of this august audience. So today we shall be discussing PET-MRI hybrid imaging, a game changer in oncology. So PET-MR is an emerging technology. It's an amalgamation of both functional and molecular information. It's a mix of the quantitative aspects of MR and PET with exquisite anatomical precision to provide us a wholesome PET-MR information. So to start with, PET-MR was a sequential or a tandem imaging. That means the PET and the MR systems were placed in two separate rooms, and the patient finishes the MR imaging and goes into the next room for the PET imaging. That was done because of a lot of technical challenges. So with evolution and evolvement, there came a day of simultaneous PET-MR imaging. That means it was an integrated PET-MR system, both together in the same system. So the patient undergoes simultaneously both the MR as well as the PET imaging. So this was started from 2010. So there was a lot of technical challenges which the engineers had to set right because of the strong magnetic fields in the MR system, giving rise to a lot of eddy currents, and the photomultiplier tubes, which are highly sensitive to the magnetic fields. There's a lot of Lorentz force. So both these fallacies had to be taken care to provide us with the PET-MR system. Nextly, when the PET insert had to be kept inside the MR gantry, the bore size had to be reduced. And they also had to improve on the PMTs. So the SI PMTs have been found to be the ideal electronic gadgets these days in the simultaneous PET-MR system. The main technical challenge after this was to address the attenuation correction, where the Dixon image sequences are taken to produce the better, higher image quality. Because of the reduction in the bore size from 70 centimeter in the PET-CT to 40 to 50 centimeter in the PET-MR, we get to see truncation artifacts because of the limited field of view. So this also has to be taken care, and which was taken care in the present system which is available. We also should not forget that patient comfort is a bit difficult in the PET-MR systems because of longer imaging times. So we need to schedule the patients and see which patient can be accommodated in that, because the bore size is smaller. So any patient who has an abdominal girth of more than 50 centimeter, has metal artifacts, hardwares, cannot be taken up for a PET-MR image. So we need to understand some practical points prior to starting a PET-MR program. What are the things which we need to set up, the workflows, the different sequences when we join the MR and the PET together, what are the standardization of the protocols, and how to take care of the attenuation correction. There are multiple vendors, Siemens, GE. I will also show you our plan in our department, how we have gone ahead. We also need to take the regulatory approvals, which are country specific, but the PET-MR approvals are almost nearly the same as the PET-CT. So just to understand the department layout in our hospital. So low dose area to a higher dose area. So we have the gamma cameras, the patient preparation areas, the PET-CT and the PET-MR, and these are the injection rooms all in one place. And these are the consoles where the reporting is done. So normally a whole body PET-MR imaging goes without saying that you also need to do the regional imaging of the area of interest. The scan time typically is nothing less than 1 hour. It goes on to another 15 minutes to half an hour if regional MR sequences are to be considered. While the MR sequences are going on, the PET imaging also happens. So you get a very good count statistics in PET-MR images on the whole. So we normally take 5 bed positions along with the regional imaging. And the contrast study, for the IV contrast, we use the DOTAREM. And as with the PET-CT, you also need to understand the creatinine clearance. And we have to keep in mind that patients can have a rare complication by using the IV gadolinium contrast, that is the nephrogenic systemic fibrosis. So we'll just run across through the protocols. So these are the general protocols which one needs to follow for a whole body PET-MR. So the PET imaging, as I told, continues throughout the study of the MR sequences. These are the multiple sequences which is normally taken, the Dixon sequence, T2, T1, and the diffusion weighted and the ADC maps. We also use the contrast as we just discussed today, and the regional scans also are required because we need to give the report of the regional area of interest also in oncological setting. Plus, regional imaging sequences depend on the clinical indication of the patient. Patients who are suspected to have liver problems, you obviously need to take a triple phase scan. And for the prostate, definitely we need to study the multiparametric imaging also. So this is how the coils are placed on the patient. Patient needs to be screened well to see that he doesn't harbor any metal things like watch, earrings. Those things have to be clearly monitored and removed prior to subjecting the patient into the PET-MR room. And you need to place the coils symmetrically and properly. And it's always the head to mid-thigh imaging. And the lower limb is to be imaged only when there is a clinical suspicion or the malignancy like melanomas. You need to involve the lower limb, and also for sarcomas. So here you see the first image is the placing of the coils. The next is the whole body sequence, and finally is the fused PET-MR image. So let us now discuss the attenuation correction, which was a major challenge for the PET-MR simultaneous imaging. Normally, the attenuation correction is done using the mu map generation using the Dixon sequences. The other attenuation correction methods which have been used by the vendors are the segmentation technique, using the template or the atlas-based technique, and also the joint estimation techniques. So in the segmentation techniques, one needs to understand that the attenuation, there is a difference in the attenuation in the body tissue matrix, that is the water, fat are having different attenuation coefficients. So we need to add counts to them to get a good quality image. Each voxel in the lung, fat and soft tissue have to be corrected so that we get a good image quality for interpretation. The other method which was used for the attenuation correction is the template or the atlas-based approach, where stored templates of a database are used to overlay the images and to find out the patient-specific, tissue-specific attenuation coefficients, which are added to the image for the attenuation corrections. So these are the indications of PET-MR. It's a selective usage. Only certain specific malignancies in both oncological and non-oncological indications are to be subjected for the PET-MR because of the longer imaging time, and Patients who need excruciate and anatomical details are subjected to the PET-MR imaging. So the head and neck, pancreas, liver, prostate, musculoskeletal like multiple myeloma, soft tissue sarcomas, gynec malignancies, brain, breast are the oncological indications for PET-MR imaging. The other non-oncological imaging is for the epilepsy evaluation, myocardial inflammation, and for diabetic foot complications where we need to know a lot about the structural anatomy of the diseases. So of the 3,650 cases which we have been doing in the last 5 years, the majority of the oncological applications in our center is for the prostate, which is around 28%, followed by liver and lung. Head and neck also is, we have done around 15% of our patient load is from the head and neck malignancies. Of the non-oncological, the epilepsy evaluation is a major program where around 67% of our population belongs to the epilepsy. So let us now discuss the role of PET-MR in the TNM staging. So where does it stand? It provides extraordinary information about the accurate tumor localization, the extent, the involvement of any tumor invasion into the adjacent structures. Does it involve the neurovascular structures? And all this is best exemplified in the endometrial malignancies, CA cervix, prostate. Not only the staging, PET-MR is also extremely useful to target the right site for biopsy. When we compare the PET-CT, the PET-MR does not have great diagnostic accuracy because both CT and MR rely mostly on the size criteria. Here, another word of caution is when you do the PET-MR imaging, the lung nodule pickup rate is very poor. So we need to supplant ourselves with a high resolution inspiratory CT so that we don't miss out on the lung nodules. Coming to the M staging, PET-MR is also equally efficient when compared to PET-CT in providing us information about the liver, brain, skeletal metastasis. Obviously, for the marrow involvement, MR is perfect. When it is additionally with the FDG PET study, we can find out the right site of marrow biopsy if anything is contemplated. It also has a great role to play in the assessment of response to chemotherapy or radiation. Here, the DWI images from the MR sequence are used to assess the tumor response. Also, we see the SUVs provided by the FDG to see for the tumor response. It also reflects the tumor cellularity, and restaging for surgical resection is also well exemplified by the PET-MR imaging modality. So let us now discuss the role of PET-MR in specific organs. So let us start with the prostate malignancies. So this T-staging, what is the most important information that one derives from a PET-MR is not only the volume and the dimensions of the primary lesion, but also its accurate site of localization in the 39 segment prostate model. We also like to see the T2 and the DWI characteristics, extraprostatic extension, periprostatic spread. Is there really any involvement of the seminal vesicles, retroprostatic angle, and neurovascular bundle invasion, which is simply not possible for us to address in the PET-CT component of the studies? What we have found is there is an extraordinarily good agreement of PSMA PET with the T2 weighted images on the PET-MR. It also equally correlates with the Gleason score of the patient. So more aggressive the disease, more is the PSMA ability or the uptake. And we definitely have a great role to play in the transitional zone lesions, patients who have been subjected to recent biopsy because there the MR can be fallacious. Similarly, they are a bit, there is some amount of false reporting in the post-RT settings in patients with prostatic carcinomas from the MR side. So just to give you an overview, this is how the different areas of the prostate, the 39 segment model, can be accurately labeled from a PSMA PET-MR imaging. The other image shows the regional nodes in green color and the distant nodes in red, which can be very easily and straightforward reported by a PET-MR PSMA study. And we have also already discussed that the PET-MR in the NM staging, it is definitely superior to the MR when we are talking about the nodal staging, because many times the PSMA avid nodes stand out. They may be less than in very small subcentimetric, millimetric nodes, which can be easily missed on the MR stir bright sequences. So it is a very good tool for us to upstage the nodal status. And there is no extra additional diagnostic accuracy when using the MR alone. And obviously for the M staging, there is no better answer than doing a patient with a PSMA PET. So just to cite certain examples for prostate malignancy, this is a patient who is who's undergoing a whole body PSMA PET MR for recently diagnosed CA prostate, and here we can see that the arrow is pointing to the seminal vesicles. So we are definitely going to report this as a patient with not only with the primary disease but also with the extra prostatic spread into the left seminal vesicle. So we need to understand that the PSMA PET can provide us better information on the extracapsular invasion, extension into the local organs, and also for the rectoprostatic angles. So this is one more case where I would like to highlight that this is a patient who has undergone a recent biopsy, and you can see that the MR area which is showing a false positivity actually does not show a PSMA uptake. So that can be falsely reported on the MR alone as a site of positivity, while we show that not only there is a PSMA avid uptake in the other zones of the prostate, but it also shows involvement of the rectoprostatic angle. So PET-MR is a very good tool to upstage the disease instead of relying only on an MR study. It's not moving. Now it has gone. So let us now go ahead with the head and neck malignancies. This is one more area where the PET-MR provides exquisite anatomy, tumor extent, delineation from the FDG PET-MR imaging. It is extremely useful in post-operative setting to identify soft tissue recurrence. And definitely the PET-MR imaging is superior to PET-CT due to the high soft tissue contrast, because the MR surface coil improves the spatial resolution. We have already discussed that MR has problems in identification of the tiny cervical nodes, which can be improved with the FDG. So with the excellent PET-MR images, all the lymph nodes in the head and neck malignancies can be easily identified by FDG PET, because we do not rely only on the size criteria. But we also need to understand that we can have artifacts because of the dental procedures, if any, patients who have undergone hypoglossal nerve palsies, if there is a thermogenic adipose tissue activation, you can have false positive both MR and PET studies, which needs to be kept in mind and can be easily correlated with both simultaneous interpretation of images. So we move on to a few case series of head and neck malignancies. The first case is a patient with suspected tongue recurrence. So you can see the MR images actually does not provide any information at the site where the FDG uptake is seen. You can see the arrow marks. So that is the site of increased FDG uptake, which clearly demonstrates that it is a site of recurrence involving the left lateral border of the tongue. This is a patient who has undergone partial glossectomy. And so here FDG PET MR has been incremental in identifying the right site of primary pathology. And we are also useful because this was the patient with no other lymph nodal or distant metastasis. So the patient can be managed according to what the PET-MR imaging has shown. The next case is also a patient who has come to us for staging, and you can see that the PET-MR imaging clearly localizes the site of the primary in the left side of the tongue, posterior part of the tongue, and also in the MIP image you can see that there is a lymph node which I have not shown here, but it is a patient with a highly localized disease and only one of the nodes in the left side of the neck being positive for malignancy. So this is another patient where there is a distortion of the anatomy because of the surgery. So in all those cases, the MR becomes a bit difficult and challenging for the radiologist to report, but it's an easy thing for us because wherever you can see a site of FDG avidity, you can clearly, confidently report that this is a site of the tumor recurrence. So here, so this is a nodular proliferative lesion in the left side of cheek, and it is also seen to be infiltrating the buccinator muscle. Apart from that, we were also able to show that there was a congruent stir bright and FDG avid submental and left level 1B lymph nodal metastasis. So in all these patients who have undergone surgery post RT, the answer is please suggest and do a FDG PET-MR imaging. Coming to the brain malignancies, we fall short because of the small size of brain lesions. So the exquisite anatomical details are better provided by MR, but with amalgamation of PET-MR, we can clearly and confidently report patients in post-radiation settings to identify if a patient has a recurrence, tumor recurrence in the brain, or it is only a radiation necrosis, because we cannot go wrong. Only when there is an FDG avidity in the site suspected to have the lesion, we see an increased FDG avidity, which can be clearly said that it is not a radiation necrosis, but rather a tumor recurrence. And because FDG is the basic substrate of brain, there is a limitation for us in identifying very small and low metabolically active brain tumors. But this is being circumvented with availability of newer radiopharmaceuticals like the amino acids like methionine, with the choline lecithin based RPs and various receptors which can be used to study brain metabolism and receptor imaging to provide more information. So these are few of the examples. You can see multiple tiny lesions in the brain which are FDG negative, sheerly because of the size of the lesion and the FDG normal uptake in the brain. This is a patient with CA breast where a meningeal uptake has been clearly identified in a whole body PET imaging, although the patient seems to have lots of bone metastasis, but the brain meningeal involvement was clearly picked up by a PET-MR imaging. So coming on to the gastrointestinal malignancies, we know that PET-MR is useful for staging and follow-up of gastric malignancies, but it is extremely useful for T-staging in rectal carcinoma and characterization of liver lesions, because it also gives us information regarding the positive tumor margins, which can be either because of the primary tumor or because of tumor deposits close by. Also, we have a lot of information provided by a wholesome PET-MR imaging, because peritoneal and disseminated mets can be falsely, our FDG PET avidity is slightly blunted in peritoneal metastasis, which can be circumvented by using a complementary MR imaging. So in those cases, a PET-MR imaging helps us to upstage the disease. And we are also very useful in the evaluation of hepatocellular carcinomas and cholangiocarcinomas. And also in the patients with pancreatic malignancies, the lesion localization and neurovascular bundle involvement can be easily reported from a PET-MR. So in this situation, I will also like to tell that we have problems in identifying primary liver malignancies, cholangiocarcinomas. So this is where F-choline PET-MR is extremely useful. It not only finds out the multiple sites of liver lesions which were FDG negative, it also shows us the extent of the disease and involvement of any other nodal or distant metastasis. And hepatic metastasis detection in colorectal carcinoma is also improved when we are using an additional MR imaging. So this is a patient with a cholangiocarcinoma, and we are able to show that there is a positive uptake in the primary confluence area, and the patient is having no other sites of lymph nodal or distant lesions. So the surgeon can concentrate and go ahead for the management based on the PET-MR imaging modality. So let us move on to the gynae malignancies. Here the MR provides information on the tumor size, extent, and most importantly the parametrial wall invasion. It also gives us information on the lymph nodal and metastatic status. So the PET-MR actually performs better over other imaging modalities as per the literature review. In the endometrium, it gives a lot of information along regarding the myometrial depth invasion. It provides information on the paraiotic or the pelvic nodal status, so that surgical management, if any, can be guided based on the PET-MR. And it is also very important in stage 3 disease, and we can also try to fuse the MR and PET database sets if the PET-MR system is not available, so that we can try to circumvent the inaccuracies of the urinary bladder and the uterine positions. So an example of a PET-MR in a patient with early stage cervical malignancy, it not only shows the tumor areas, but it also gives us information on the parametrial involvement. So this is a patient with query CA cervix or endometrium, and the PET-MR imaging has been useful to identify the primary site of malignancy in the cervix and the lower uterine segment with a minimal right parametrial extension. Patient, it was a localized disease with no involvement of regional or distant nodes and metastasis. So this is another example of a locally infiltrative CA endometrium. So we have access to multiple other radiopharmaceuticals. Here we will be touching upon the choline PET imaging with PET-MR. So as we just now discussed, FDG can be notoriously negative in low-grade hepatocellular carcinomas. So in those patients, we have undertaken a study to compare both FDG PET-MR along with choline PET. So this is one such patient where we found that the segment 2 liver nodule was slightly better appreciated with the choline PET when compared to the FDG. This is the area which we are able to show. So this is another patient who had both simultaneously FDG PET and a choline scan. So you can see that this is the FDG PET. You hardly are able to make out the brain lesion, and the PET-MR is clearly showing us a enhancing lesion parietal area, which is showing a positive choline uptake. So this is the beauty of choline. So to conclude, PET-MR is a very powerful and emerging diagnostic modality which can be used and should be used only in specific clinical conditions. It increases our understanding of the tumor biology and behavior so that we can go ahead and guide and personalize management of these patients. It is very useful in the delineation of small tumors, especially in low metabolically active tumors. It provides more accurate anatomical details. Although we need to be worried about the setting up of the PET-MR because it's costly, and the amount of cases which one can do per day is slightly less, but definitely it can be specifically used for the group of patients who derive the maximum benefit. We also need to see the patient compliance, and it definitely produces much less radiation exposure, especially to young patients with lymphoma who need repeated imaging. So to do away with the radiation exposure by a PET-CT, you can definitely recommend doing serial PET-MR studies in them. We need to work together with the radiology colleagues to give the best information. Thank you very much for patient listening.
Thank you, Professor Dr. Padma, for the very insightful talk. We shall proceed to the last talk of the session, and the speaker is Dr. Omar Hussein, who is the director of the PET-CT unit in Misr Radiology Center in Cairo, Egypt. He graduated from Cairo University and obtained his master's degree in radiodiagnosis from Ain Shams University in 2014. He is a fellow of the Royal College of Radiologists, London, UK. He then obtained his master's in nuclear medicine at the Ain Shams University in 2018. Under his leadership, Misr Radiology Center became the first site in Egypt to offer diagnostic services. He is actively involved in research and has recently published on the role of technetium-99m PSMA SPECT in prostate cancer.
Hello, good evening. It's my pleasure to be invited today for the National Conference of Nuclear Medicine. My name is Yehia Omar. I'm a radiology and nuclear medicine consultant working in Cairo, Egypt. And it's my pleasure today to be presenting our experience using technetium PSMA SPECT in cancer prostate patients. So here are my disclosures. So I want to divide this presentation into 3 parts. The first part is to start by the basics a little bit, which is why do we need PSMA PET-CT and its indications? And then move to why do we need technetium PSMA SPECT imaging? And of course, the main topic for today, which is our experience using technetium PSMA SPECT with case examples. So let's start by the first part. Why do we need PSMA PET-CT? So PSMA, as you all know, is short for prostate-specific membrane antigen, and it is a transmembrane protein that is overexpressed in cancer prostate cells. And by targeting these receptors on cancer cells, we can have a much better diagnostic scan compared to conventional imaging as CT and MRI. And that leads to having a more accurate disease staging for patients. And then hopefully at the end, that leads to better therapeutic management plan and better patient outcome. So at the end, that's the mission for having any new diagnostic scan that lead to a better management and a better patient outcome. And that's what PSMA PET-CT have done in certain areas, and still trying to prove itself in other parts. So I want to move to the guidelines, the most famous guideline, which is the NCCN guidelines, which helps us communicate with our colleagues in oncology. That's the easiest common language to have, the NCCN guidelines. And I want to quote this paragraph, which is, due to the increased sensitivity and specificity of PSMA PET to micrometastatic disease compared to conventional imaging as CT and MRI, and this is at both initial staging and recurrence, PSMA PET can serve as a front-line imaging tool. So this is very important, because in the past, PSMA PET was only used when conventional imaging was negative. But now we can use it as a front line. And that's what we're doing now in our practice in Egypt. Now let's move to our guidelines now for the nuclear medicine. And this is the appropriate use criteria on PSMA PET imaging from Journal of Nuclear Medicine. And these are the most common clinical scenarios. I'm going to highlight the most important that we are now using routinely in our daily practice. Of course, they are the initial staging of unfavorable intermediate, high risk, or very high risk prostate cancer patients, whether upfront or whether after having a negative conventional imaging or oligometastatic on conventional imaging. And also, of course, in PSA persistence or PSA failure after radical prostatectomy or after radiotherapy. And these are the most common indications we see now in our daily practice. And I feel that for the past 1 year or 2 years, the referrals are increasingly asking for PSMA PET-CTs. Our oncology and our urology have been adopting it greatly the past period, and they are seeing much accurate staging of the patients, and hopefully, again, as I said, better patient outcome. So now that's the PSMA PET-CT, and that's the indication of it. Now let's move to the second part, which is, why do we need technetium PSMA SPECT imaging? We need it simply because PSMA PET-CT is not available everywhere. It is not accessible for all patients. For example, in Egypt, we only have PSMA PET-CT in Cairo, the capital, and all other cities, patients do not have access to PSMA PET-CT, so they have to travel to Cairo, to the capital, to access these investigations. And of course, it's not easy for patients to be traveling to just do a diagnostic scan. So the question was, can we find an easier alternative or a substitute to PSMA PET-CT to avoid all the hassle for the patients traveling to access this imaging? And by doing so, through technetium PSMA, we can have a wider availability of this technique, and now more patients can access PSMA imaging easily. So that's the main idea behind why technetium PSMA. Wider access and easier for patients. And it's easier because of two things. I want to start first, of course, the machine. Technetium PSMA is performed on a SPECT machine compared to PSMA PET, which is done on a PET-CT. And of course, gamma cameras or SPECT are much wider availability than PET-CT machines. The price of a gamma camera is almost 25 to 30% the cost of the PET-CT, which makes it widely available. So the number of worldwide SPECT scanners are almost more than 4-to-1 compared to PET-CT. So almost many cities have SPECT machines and gamma cameras, but they don't have PET-CT, and that can be very interesting for the patients and also for the Nuclear Medicine Society to offer this technique in sites that do not have availability to buy a PET-CT machine. The second important point which facilitates technetium compared to PSMA PET is the easier access to tracer. So we have a technetium PSMA, which is for the SPECT, And of course, for the PET, you can either have a gallium or fluorine PSMA. So the technetium, of course, needs a technetium generator, which again is easy and widely available in most cities. And we need, of course, a basic hot lab infrastructure for labeling and QC. Now for the gallium, we need a more expensive gallium generator and, of course, more advanced labeling procedure and QC compared to technetium. And to have a fluorinated PSMA tracer, of course, you need to have a cyclotron, whether in the hospital or nearby, and is going to supply your department with fluorinated PSMA tracer. And that makes technetium PSMA solves a lot of the hassle and trouble for the Nuclear Medicine Society as well for the patients. So now let's move to the main topic for today, which is our experience using technetium PSMA. So let's start by the labeling procedure. So we got the kits from Telix Pharmaceuticals, which was part of the Nobel Registry, and labeling was done with almost 15 to 20 millicuries of technetium as supplied by Telix. And then there was a heating for 10 minutes and then followed by QC. So the labeling procedure was pretty straightforward, like any other nuclear medicine exam. Now moving to the imaging procedure, and this part is a little bit tricky because in our department, we do not have a dedicated SPECT-CT machine. We only have dual head cameras. We have two machines, but they are not SPECT-CTs, only SPECT. So what we did to solve this issue is that we acquired SPECT acquisitions and planner on our gamma camera machines, and then the patient was sent to be imaged as a CT separately acquired on another machine. And then later on, the images were fused together using a software. So we had the volume of the SPECT and the volume of the CT from different machines and then fused together on a software. So let's start by the cases. This is the first case, case number 1. That was a 75 years old male patient presented with newly diagnosed cancer prostate and referred for primary staging. The Gleason score was 4+4 and the PSA was almost 100. So at the beginning, we wanted to image the patient at different time points to see where is the optimum time. So this is the initial imaging. As you can see, there's increased activity in the blood pool. That was after almost 10 minutes. And that was after 1 hour post-injection. You can see more uptake in the lesions and more physiologic organ uptake. And that was 3 hours post-injection. And we feel that the most appropriate imaging timing for technetium PSMA for this kit is around 3 hours. As you can see here, we can faintly see something in the left side of the pelvis, also something in the center, which could be prostate or bladder, also something very faint in the right side, and maybe something very faint here. So I want to highlight that planar imaging in technetium PSMA is not enough. We need to have SPECT and we need to have CT. For example, on the pelvis, these things, this is the zoomed image now. As I said, we have something on the left side, something in the center, and maybe something faintly seen in the right side here. But as you know, now we do not see bones only. Now we can see soft tissue. So we don't know what we are seeing. That's why we need CT and fusion images. And now we can see and know what we are seeing here. We can see this is the prostatic lesion. It was not the urinary bladder. And now we have a large left iliac bony lesion and a metastatic infiltrated right pelvic lymph node. That's why acquiring, if you have a SPECT-CT, this is of course the best scenario. If you don't have, then I highly recommend having SPECT images and fusion of CT, because there's a big difference. Then we wanted to do comparison between technetium PSMA and gallium PSMA in the same patients and try to compare different levels. So this is the same cut section. This is the technetium on the left side, and that's the gallium on the right side. We wanted to do a comparative analysis between the prostate level, the nodal level, and the osseous level. So let's start by the prostate. So that was the appearance in the gallium scan. As you can see here, we can see prostatic lesion, PSMA avid lesion, occupying most of the peripheral zones and probably encroaching also on the central zone. And that was in the gallium scan. Now let's see the technetium scan in the same cut section. And as you can see, it's almost the same appearance of the prostatic mass. Of course, the sharpness and tumor delineation is not as good. And this is something, of course, we know because we are comparing the SPECT camera with the PET camera. Of course, they are not similar. So probably the tumor demarcation will be less. So things like extracapsular extension or seminal vesicles infiltration will not be easily detected, of course, in technetium PSMA. But again, that's not the indication of the scan. The purpose of the scan is to see where is the lesion and any metastatic lesions in the body. So of course, there will be some drawbacks, but again, overall, we can see almost the same appearance of the prostatic mass. Now let's move to the nodal level assessment. So we can see here a PSMA avid, pre-sacral or left external iliac lymph node, and here it is in the CT, and that was almost around 10 millimeters. And when we see the technetium scan fused with the CT, now we also clearly see the lymph node, easily seen. When we go to a higher level in the abdomen, now we have a left para-aortic lymph node and a pericaval lymph node. And specifically the one on the right side, that was small, that was almost 8 millimeters. And when we see the technetium, again, the same lymph nodes were detected easily here and the other one here. So these were almost 8 millimeters. Now let's move to a lower sized lymph nodes, like this one, like the left internal iliac lymph node. As you can see here, this is a tiny node, almost around 6 millimeters. This one was not accurately detected in the technetium PSMA, as you can see here. Of course, we had a right-sided node, and that was around 10 millimeters. It was detected in the technetium, and of course, the large left iliac bony lesion was also clearly detected. So we think that the threshold of the size to detect the lesions, it seems to be between 8 to 10 millimeters. Above that threshold, technetium PSMA can usually detect the lesions. If we go below that threshold, usually we will not be able to detect it, like in this case. Now moving to the bony lesions, in this case number 1, this patient had a sternal bony lesion, as you can see in the gallium, and in the technetium, again, clearly seen. However, when you move to a smaller bony lesion, like this one, in the left sacrum, as you can see, it was sclerotic in the CT here. This lesion was not detected in the technetium. Again, we have the same large left iliac bone, but the sacral was not seen. So again, almost also the same conclusion. This sacral bony lesion was around 7 millimeters, so size will matter to detect lesions in the technetium PSMA. So now let's move to the second case. So this is a 59-year-old male patient with history of metastatic cancer prostate, diagnosed 3 months ago, managed by hormonal therapy. And what's interesting in this case is that the PSA level is 0.1 nanogram. Again, we imaged the patient at different time points. That's the initial time point with increased activity in the blood pool, then after 1.5 hours, and then after 2.5 hours post-injection. And that's the SPECT image, the volume of the SPECT. This is not a planner. Again, at this very low level, the lesion is not clear. The image is noisy. Maybe there is something here. Probably from this image, you cannot be confident. Maybe there is something in the pelvis. Again, not confident. That's why I'm highlighting that several times that we need cut section images. So let's move to the cut section of the same patient. This is the prostate of the patient. Now we can see clearly uptake in the left side of the prostate, the fused images. And then there was increased uptake in pelvic lymph nodes. Here they are in the CT. This is the left side nodes, and these are the right side. And here they are in the gamma and in the fused images. And then higher in the abdomen, we had an abdominal lymph node seen here. And here it is clearly seen in the technetium as well as in the fused. And higher in the superior mediastinum, again, we had an active lymph node clearly seen here from the axial sections and not seen easily from the volume or the planar. And also I want to put this very straight. This is the technetium for this patient, and this is the gallium for the same patient in the same week at the same low PSA level. Of course, gallium PSMA is better than technetium. This is something that we need to highlight. And of course, if the patient can access gallium PSMA, this is the best option. But what we are talking about, what if the patient could not access gallium PSMA? So from the volume of the images, of course, the lesions are more clear. Now we can see the superior mediastinal node here, as well as the abdominal, as well as the pelvic node, of course, easily seen in the gallium. But again, when we see the cut sections, both of the lesions are almost seen. So that's the upper row, that's the gallium images, and these are the same images that we've just seen. So this is the superior mediastinal node, here it is, and here it is in the technetium. So again, most of the lesions are seen in the fusion, but with lesser details and lesser quality. And of course, again, that's due to the difference between the SPECT cameras and PET-CT cameras. But again, most of the lesions are seen from the fusion images. Now let's move to the third case. So this is a 71 years old male patient with newly diagnosed prostate cancer and referred for initial staging. And as you can see, this is the bone scan of the patient. Of course, you can see diffuse metastatic bony lesions in the axial and proximal appendicular skeleton. And now we performed also technetium PSMA to compare between it and bone scan. And here are the technetium PSMA, that's the anterior, posterior, as well as the SPECT volume. It was acquired on 2 frames. As you can see, this is the first frame here, and that's the second frame, and stitched together. So the difference between technetium PSMA, as we all know now, that it is not only seeing bone. So now you can see all the bony lesions seen here, and that's the sagittal image of the bony lesions of the technetium PSMA, but also added on the bony lesions compared to bone scan. Of course, we can see the prostatic lesion as clearly as it here in the axial and the sagittal, and of course we can see in the same patient metastatic lymph nodes as seen here. So that's the main idea behind technetium PSMA, and I think in the future it can have a role to replace bone scan for cancer prostate patients, because I don't only see bones, but I see all the lesions, the soft tissues, in a single exam on gamma camera machine, which is extremely exciting for nuclear medicine. Now moving to the final case, again a comparison between gallium PSMA and technetium to highlight the difference. So this is a 68-year-old male patient with newly diagnosed cancer prostate, referred for initial staging. The PSA level is 74 and the Gleason score is 4+5. As you can see in the gallium PSMA, multiple metastatic bony lesions, and here are the technetium images. Of course, as I said earlier, gallium PSMA images are much clearer, easier to be read, and the lesions are sharper and more clear. In the technetium, probably also because the liver has high uptake, similar to the fluorine PSMA, the images are not straightforward, at least from the planar imaging, and that's why we need the cross-sectional imaging. But when we go to the cross-section, you will see that most of the lesions look the same, and here they are. This is the prostatic lesion, As you can see here, this is the gallium, and here is the left sided prostatic lesion. As you can see here, the gallium, and in the technetium, it almost looks the same. Also, we have bony lesions in the right side of the pelvis. Here they are almost similar to each other. And these are the sagittal images. Again, the prostatic lesion seen here. Of course, much clearer and sharper demarcation in the gallium. We have the bony lesions almost the same. Here they are compared to here. But maybe this pre-sacral lymph node is more obvious in the PET, for example, because it's smaller compared to the technetium. But again, most of the lesions and also these pelvic lymph nodes look almost similar. So I get almost the same feeling when we have the technetium and gallium, but it's mandatory to have cross-sectional images. So to summarize, from our experience, technetium PSMA could be a very good substitute in case of no access to PSMA PET-CT, and it can detect most of the lesions above 8 to 10 millimeters compared to gallium PSMA PET-CT. And finally, as I said several times, it needs SPECT-CT machine, or at least acquiring SPECT and fuse it with CT like we have done in our center. Thank you very much.
Thank you very much for the talk. Now we have come to the Q&A session. May I invite the speakers to the front for the Q&A? So I'd like to open for questions from the physical delegates first. Anyone with question, please kindly step up to the mic.
This is a question from yet the prep pathway also for yes. No, because PET-MR for epilepsy, there's no point in doing for the whole body. So we limit ourselves only to the brain. And it's usually intractable, so they have lots of episodes. So we need to schedule the patients. Sometimes it should be done under GA, general anesthesia, and many of the times they are small children. So we need to time ourselves according to the patient convenience. And we also need to have accessories like epilepsy-specific accessories, because moving in the accessories into the PET-MR room is highly dangerous. So you need to have specific things accordingly. I'm sorry, I didn't get you. Timing. Yeah, actually the waiting time is the same for both the FDG, PET-CT and PET-MR. But obviously there may be some more time required to set up the patient for the PET-MR positioning, because you need to place the surface coils for the patient. But the technologists are well trained, so they are aware of the radiation safety concerns. So they do everything quite fast so that we do it. But the waiting time is the same, 45 minutes to 1 hour. But throughput is definitely higher. It takes around 15 to 18 minutes for to complete the head to mid-thigh imaging of a PET-CT. While for the PET-MR, the whole body itself takes nothing less than 60 to 70 minutes. Epilepsy. Are you asking only about epilepsy? Yes, for now it's epilepsy. Yeah, for epilepsy, for the PET-MR. Slightly more. No, it takes slightly longer for the MR sequences to be acquired, because they have some protocols for the MR epilepsy things. So we need to slightly take, but obviously that will be much less than when we take the entire head to mid thigh time.
Actually, in a PET-CT epilepsy protocol, it takes only 15 minutes, because the acquisition of the PET is only around 10 minutes, and you don't do a contrast study, you do a non-contrast CT, so it takes 5 minutes. But in PET-MRI, it takes around 30 minutes because it is not due to the PET acquisition, but MR specific, epilepsy specific MR protocol. So in that, more number of sequences are there, and also they do a contrast study. So the entire time is for the MR sequences, but the PET imaging can be continued for the entire period. So the image quality is much better.
I do have a question regarding the Sentinel mode. Prof, do you have any experience on that, or does your center has any experience on using a fluorescent agent or a hybrid fluorescent radio tracer agent?
Actually, we don't right now have a probe which can detect both, but we do blue dye plus Sentinel with radio tracer. For example, you can do a carcinoma breast. To start with, we have done the previous day we would have injected technetium labeled sulfur colloid, and we will be probing the patient the next day. And blue dye can be injected just before the surgery. So both can be done. But your question I understood. Using the equipment, do you have a probe which can detect both the fluorescent and the technetium labeled sulfur colloid? Is not there. So we don't have it, but there are equipments, optical imaging and molecular imaging equipments are there. Right now I don't have it. And also we have something called portable gamma cameras. We have an experience with portable gamma cameras where we can push in the gamma camera, rather it is a handheld gamma camera, and it can be kept on the lesion, and you can show the uptake like the probe. But the probe for both is not right now available with us, but it is possible.
Okay. Is there any other questions? Okay, I think due to the time constraint, we shall stop the Q&A session here. Thank you very much, and I shall pass back to the MC.